professor at the University of California, San Francisco, and medical director of the Adult Antimicrobial Stewardship Program. I will be speaking today about recent publications that all stewards should be aware of. The objectives of this talk are to discuss recent scientific publications related to antimicrobial stewardship and to determine how to critically review the literature to guide practical approaches for stewardship intervention. This was such a hard talk to prepare because there were many wonderful articles published this year. Here was my strategy. I took publications that were published between the time of last ID Week and this ID Week by doing a PubMed search for antibiotic or antimicrobial stewardship, by looking at the CIDRAP bibliography from 2019 through 2020, and by looking at the recent article in OFID that described a baker's dozen best stewardship articles of this year. Here's how I will discuss. We're going to start by touching on a couple of randomized controlled trials that I think are very important for stewards to be aware of. We're then going to talk about implementation of core stewardship strategies in non-traditional settings and populations. We'll discuss some novel interventions, and then we'll touch on methodology and measurement, recent guidelines, and have a brief word on COVID. We'll end with some honorable mentions. Let's start. The first study you're likely aware of. This was first described in 2018, a study looking at duration of treatment for gram-negative bloodstream infection. This was performed at 2 academic hospitals in Israel between 2015 and 2017, and first reported at ECCMID in 2018. It was an open-label, non-inferiority trial that took patients with well-controlled infections after the first week of treatment and randomized them to stopping antibiotics at 7 days versus continuing for 14 days. Most of the patients, 90%, had Enterobacterales infections. 19% had multi-drug resistant organisms, most of those were ESBLs, and the majority had urinary source of infection. Notably, 22% were immunosuppressed, and this included 8% with solid organ transplants and 6.5% with hematologic malignancies. Everyone was stable, and those with sepsis, ongoing sepsis, were excluded from the study. The investigators adhered to the study assignments, as can be seen by the median duration of 7 and 14 days in the 2 groups. And when you looked at the composite outcome of mortality, failure, readmission, and extended length of stay, the outcomes were pretty much equivalent between the 2 groups. Notably, those who got shorter courses of antibiotics had a quicker median return to baseline. This approach to shorter treatment of gram-negative infections was described by Erickson et al. In one of the honorable mention publications as part of a bundle for treatment of gram-negative bloodstream infections that led to shorter durations and more oral antibiotics at that center. The next trial we'll discuss was recently published in the New England Journal of Medicine. This was a 25-center study that randomized patients with appendicitis to receive antibiotics alone versus surgery. They enrolled 1,552 patients and stratified the patients by having an appendicolith because that has been associated with worse outcomes and more difficult surgery with appendicitis. The primary outcome for this study was 30-day health status measured by the European Quality of Life 5 Dimensions, or EQ5D questionnaire. The goal was non-inferiority of 0.05 points on this scale. When they looked at that outcome, the scores were pretty much equivalent between the 2 groups, those who received antibiotics and those who had surgery, at a time point of 90 days. Now note that this was an early analysis that was done in the setting of COVID-19 because there was a lot of interest in alternatives to surgery during the pandemic when elective surgeries were canceled at many centers. The authors had initially planned a 1-year analysis. It's important to note, though, that the group that received antibiotics had increases in hospitalizations, and 41% in the appendicolith group and 25% in the non-appendicolith group ultimately had an appendectomy. This is something that's important to consider when counseling patients about the safety and efficacy of receiving antibiotics as an alternative to surgery. Some take-home from the clinical trials. Shorter courses for gram-negative bloodstream infections are safe and effective once the patient is stabilized, even if the patient is immunocompromised. Implementation strategies should be a focus of antibiotic stewardship programs. Antibiotics may be an option for acute appendicitis, though patient-centered discussions should take place. Some may avoid surgery altogether, but many will need surgery in the end. For the next section of the talk, we'll be talking about stewardship using core strategies in non-traditional settings and populations. The first couple of trials were done in community hospitals that did not have significant numbers of infectious disease trained pharmacists or antibiotic stewardship trained pharmacists to run their stewardship programs. The first one was a cluster randomized trial at 4 community hospitals in North Carolina that are part of the Duke Antibiotic Stewardship Network. These hospitals were randomized to do modified prior authorization, meaning that prescribers could get 1 dose of the antibiotic, but then had to get approval for the antibiotic from the stewardship program, versus a post-prescription review with feedback to providers. After 6 months, there was a 1-month washout period, and then the hospitals took the other approach. When they looked at the outcomes, there was a feedback from the clinicians who responded to a survey that about 50% of them changed treatment during this time due to a pharmacist recommendation. However, 31% also reported choosing non-study antibiotics to avoid interventions.
What about alphadas?
Notably, during the times when the hospitals were doing post-prescription review with feedback, there were more phone conversations, and this led to more de-escalation of therapy versus prior authorization. Only 30% who were eligible to have interventions ultimately had interventions done, so there was lots more opportunity left on the table. And of the 2 interventions, post-prescription review with feedback decreased overall antibiotic utilization and appears to be a really promising strategy to the setting. The next intervention described a telehealth stewardship program focused on broad-spectrum antibiotics, skin and skin structure infection, and lower respiratory tract infection that was done at 2 hospitals that are part of a community hospital health system. At these 2 hospitals, there were pharmacists that had no specific stewardship training who received some initial training in prospective audit and feedback on a rotating basis. And these pharmacists met 2 to 3 times weekly for an hour over the phone with an ID physician and reviewed patients on broad-spectrum antibiotics and, if time permitted, those with skin and skin structure infection and lower respiratory tract infection. During this time, the authors noted a decrease in overall antibiotic use from 821 to 777 days of therapy per 1,000 patient days. There were an impressive number of interventions made during this time, 1,419 between the 2 hospitals, and the acceptance rate was very good at 88%. Most of those interventions were related to de-escalation. There was an increase in ID consultation during this time as well. Sloan and colleagues reported a multi-component intervention that took place at 27 nursing homes, focused on implementation of core antibiotic stewardship efforts at these nursing homes. The stewardship program was really robust that they provided. It included education to residents and families, nurses, and prescribers, several different pocket guideline cards. There was a standardized system for recording antibiotic prescriptions, and peer comparison was provided during the intervention. The authors noted a 20% decrease in systemic antibiotics during the study and a 29% decrease in antibiotics for urinary tract infections, which was one of the specific focus syndromes. There was no change in hospitalization rate or other counterbalancing measures. The graph on the right demonstrates each of the hospitals over the 3-year period of the implementation. And as you can see, different hospitals had different rates over the 3 years of antibiotic use. But when you look at the median rate across all the hospitals during those 3 years, you can see that the red line in 2015 and the green line in 2016 were both much higher than the purple line in 2017, the 3rd year of the program, suggesting that as the program matured, the antibiotic use continued to fall safely. The next study that we'll discuss was a quasi-experimental single-center study at a heme malignancy unit that described implementation of 2 different approaches. The first one is the one we'll focus on, which was an antibiotic cycling program alternating months of primary gram-negative broad-spectrum antibiotic coverage with piperacillin tazobactam or cefepime on alternating months. The second intervention included a prediction rule for vancomycin-resistant enterococcus. Notably, the duration of therapy was up to the clinician, and everyone at this center was receiving vancomycin as initial treatment for febrile neutropenia. The notable findings of this study were that there was an increase in piperacillin tazobactam and cefepime use, which was offset by a very significant and profound decrease in anti-pseudomonal carbapenem use during the study period. Of note, this was associated with a significant decrease in vancomycin-resistant enterococcus rates, which was felt to be due to the decrease in carbapenem use. There were no major signals for counterbalancing measures, though the authors did note there was an increased number of patients who had candida infections. During this time, there was also increased notes of extended spectrum beta-lactamase infections, though these were likely associated with increased community spread during this time. One question that came out of this study is whether the benefit was due to carbapenem restriction or the antibiotic cycling itself. And that's a question that I think remains to be answered. But conclusions to take home from this include that carbapenem use can safely be decreased on hematologic malignancy units and may lead to secondary decreases in vancomycin-resistant enterococcus, which is an important pathogen on these units. The last study that we'll discuss related to special populations was a very large pragmatic PK study that took place at 29 ICUs with 381 patients that measured the effect of renal replacement therapy and antibiotic dosing on antibiotic concentrations. The authors focused on 3 target antibiotics: piperacillin tazobactam, vancomycin, and meropenem. The main findings of this study were that there was a very notable variability in CRRT prescriptions and antibiotic dosing across centers. And even knowing the prescriptions and the dosing, it was very hard to predict the best dosing. 25% of patients did not achieve the goal higher trough, which was defined for beta-lactams based on the time above the MIC. And for vancomycin was a number of 20. Notably, the authors also found that for those receiving vancomycin, 55% were below the lower goal trough of 15, and that a significant proportion of patients who were receiving beta-lactams had excessively high levels, which predisposed to encephalopathy. The most striking finding is that the authors found an increased mortality on both ends of the spectrum, if the trough was below 1 time the MIC or if there were excessive concentrations. There seemed to be a sweet spot to hit. However, it's hard to get there, and something to be aware of when dosing antibiotics in these complex patients. Some take-home points for the special populations and settings. Core stewardship approaches can be implemented successfully in community hospitals, nursing homes, and other non-traditional settings. These need dedicated resources and time, however. Focus on specific populations can identify tailored opportunities for improvement, and much more work is needed for dosing in renal failure. We're going to move on to talk about novel interventions in the acute care setting. The first one takes place at North York General Hospital in Toronto, Canada, which is a 400-bed community teaching hospital that performs baseline antibiotic stewardship 3 times per week, with the CCU and antibiotic stewardship programs doing handshake stewardship. They noted that duration of use was a significant issue, and that became the focus of this intervention. This intervention included a standardized script that nurses used on rounds to note that the patient was on specific antibiotics and to denote the duration of antibiotics. The physicians were then asked to respond with information about the indication and planned duration. There was some bling attached. Everyone wore a button that said DOT, what day are we on? And during this intervention, they found that though antibiotic duration of therapy or days of therapy had been increasing steadily over time, once the intervention took place, there was an immediate decrease by 217 days of therapy per 1,000 patient days, and that was sustained over time through the intervention. Bolton and colleagues described the effects of implementation of an automatic discontinuation of antibiotics policy. According to this policy, the antibiotic stewardship program could automatically discontinue antibiotics that involved dual coverage or excessive duration of therapy for agreed upon durations that included community-acquired and healthcare-associated pneumonia, COPD, sinusitis, cystitis, pyelonephritis, and skin and skin structure infections, as well as antibiotics that were being administered for more than 48 hours with no documented infection. During the intervention, they decreased antibiotic use by about 1 day per patient, and that was a significant decrease in use. And notably, fewer patients were discharged on antibiotics during the intervention, only 8% versus 18.5% in the pre-intervention period. All of the counterbalancing measures, including rates of readmissions and recurrences, were largely equal, suggesting that this was a safe implementation strategy. The next approach took place at a community teaching hospital in Toronto with 5 medicine wards, where the authors describe a pre and a post intervention that they note is high versus low intensity stewardship. The pre-intervention period included post-prescription review with feedback on 1 to 2 antibiotic classes per day, with recommendations made directly to the prescriber. During the post-intervention period, there were 2 times weekly stewardship rounds with the stewardship and the ward pharmacist, a hospitalist, and the stewardship physician. They reviewed all patients on antibiotics, not just the targeted antibiotics, essentially describing a form of handshake stewardship. During this intervention, they did find a significant decrease in overall days of therapy per 1,000 patient days, with no change in other clinical outcomes. There was also a recent longitudinal report from the Children's Hospital of Colorado that suggested that handshake stewardship is a sustainable and effective approach. Of note, this is a very high intensity intervention that requires a lot of resources and must be balanced with the marginal gain in decreased of days of therapy for the program. there have been a lot of interest in delabeling patients with beta-lactam allergies. And this article described an approach at a teaching hospital and cancer hospital in Australia that universally addressed all patients who were admitted with penicillin allergy and attempted to delabel them safely. So they took patients who were admitted with penicillin allergy and, based on history, assigned them to the high-risk allergy versus low-risk allergy group. In the low-risk allergy group, they delabeled in one of two ways: either directly, based on history of things like nausea and vomiting or other non-allergic reactions. If they had had a low-risk allergic reaction, like a simple rash, they offered the patient an oral challenge with amoxicillin. This could either be one dose of amoxicillin followed by the antibiotics that the patient needed, or if the patient did not need antibiotics, they could give a longer course of an oral challenge up to 5 days. Using this approach, they ultimately were able to delabel 355 out of 1,225 patients, or about 30%. Notably, there were 6 patients who had positive oral challenges, but none of those were IgE mediated. Delabeling led to improved antibiotic use metrics, looking at pre versus post-implementation, as well as those who were labeled versus those who were delabeled. Use of narrow-spectrum penicillins increased by a tenfold. Use of restricted antibiotics decreased by about 50 to 60%, and appropriateness of antibiotics approximately doubled. The last novel intervention that we'll discuss is an accessible rapid antibiotic stewardship test. This is called Rapid Antibiotic Stewardship Testing, or RAST, and involves taking a positive blood culture and doing disc diffusion that is read at 4, 6, or 8 hours rather than the standard 16 to 20 hour incubation. This was a report of a study that was done at 55 centers across Europe, where the centers were asked to do at least one of these tests per day on a gram-negative and one on a gram-positive for a period of 30 days. They ultimately collected 1,151 isolates, with many more susceptibility tests, given that each isolate had multiple tests done. Notable findings included that the readable zones occurred in the majority of the isolates at 4 hours. And very major errors occurred only 0.2% of the time at the 4-hour time point. These are errors where the rapid test called susceptibility, but the true result was resistance. Total errors were 3% at 4 hours, 2.1% at 6, and 2.2% at 8 hours. Most of those were the rapid test actually calling false resistance. Of note, though there were resistant organisms, there was limited numbers of CRE organisms, so that may be a hole that needs to be further studied. It will be really important to figure out an implementation strategy for this and other rapid tests, as we know that just having a rapid test alone may not lead to change in antibiotics, but being able to communicate this to teams and encourage focusing therapy is an important role of the antibiotic stewardship program. So take home from the novel interventions. Nursing involvement in antibiotic stewardship programs help to decrease unnecessary antibiotic exposure in the ICU. ASPs looking for advanced approaches can consider automatic discontinuation based on expected durations, comprehensive allergy assessments, and handshake stewardship approaches. Rapid diagnostics provide new stewardship opportunities, and implementation approach by ASPs will be key. Though we won't have time to go into the details of the content of these new guidelines and guidance, I wanted to point out 4 new or updated guidelines of interest to antibiotic stewards. The first is a new guidance describing treatment recommendations for antibiotic-resistant gram-negative rods. Next is a recommendation to use vancomycin AUC over MIC monitoring for treatment of MRSA infections. Third is a core antifungal stewardship best practices guideline that describes some core stewardship efforts that should take place related to antifungal use. And last is a long-awaited update to the CAP diagnosis and treatment guidelines. Next, we're going to discuss some issues in methodology and measurement. Van Katwick and colleagues applied the Standards for Quality Improvement Reporting Excellence, or SQUIRE, checklist to studies that described policy interventions to reduce antibiotic use. They found that most antibiotic resistance studies did not follow the SQUIRE reporting guidelines. In fact, the mean score was reporting only 10 of the 18 items on the checklist. And more notably, only 20% of the studies described their interventions in a way that could be easily replicated. This is really important for those of us who report antibiotic stewardship interventions to ensure that others are able to follow the interventions that are being described in the literature. The next report is a summary of data visualization techniques that's really a practical article that helps to describe how data visualization can help to communicate stewardship messages and give some really useful information about data visualization. The third report to note is an updated NHSN description of the NHSN standardized antimicrobial administration ratio models from 2017. This is really important for any center that's reporting to the NHSN SAR program so that they understand how their data and how their SARs are being generated compared to other hospitals. Take home for guidelines and methodology. National and expert guidelines provide a reference for local adaptation and implementation. Reporting quality of stewardship intervention studies must be better, and presentation of data can help to improve stewardship messaging. Though the main focus of this talk was not on COVID-19, I couldn't pass up a discussion of the role of COVID-19 in stewardship programs in the current time. There are four main points I wanted to make, and many papers have been written on some of these topics that are cited below. First, many programs are leveraging their existing stewardship electronic medical record tools for COVID-19 patient management, and this has been described nicely in the paper by Stevens et al. Second, many stewardship programs are using their structure to help with COVID-19 medication authorization and distribution, including things like remdesivir and convalescent plasma. Next, there are several reports describing incidence and diagnosis of bacterial and fungal co-infections, which occur only in a minority of patients with COVID-19. And that brings us to the last point, which is antibiotic use guidance. Antibacterial use is very common in patients with COVID-19, despite only a minority having documented bacterial infections. And stewardship programs can be very important in helping to limit the unnecessary exposure of antibiotics to these patients. We're going to end by going through the contender studies. There were many studies that had really wonderful points, and I've included the studies in an appendix for your reference. I encourage you all to look at them. Implementation of a bundle for gram-negative bacilli led to shorter durations and earlier oral transition. Among patients with Enterobacterales bloodstream infections, longer durations of anti-pseudomonal beta-lactams increased rates of C. diff infection. An electronic dashboard with facility-level comparison to other hospitals led to decreased anti-pseudomonal and MRSA antibiotic use. Prescription of oral antibiotics to persons who inject drugs who self-discharge decreased readmissions. A cluster randomized trial of antibiotic timeout did not change antibiotic use. Peer comparison improved emergency department discharge antibiotic use, but there was still much opportunity that persisted. Propensity-matched patients received shorter courses for syndrome-associated bloodstream infections, had similar outcomes to those who got longer courses. And while literature supports prompt initiation of antibiotics for sepsis, evidence is lacking for less severe syndromes, and a delayed approach may be reasonable while confirming diagnosis for these syndromes. We'll continue on our second page of contenders. 60% of fluoroquinolone DOT for inpatients were prescribed on discharge. Hospitals without robust stewardship programs had more prescriptions and more inappropriate use of fluoroquinolones. Lots of opportunity for improvement existed at all hospitals. Education and personalized dashboard improved outpatient antibiotic acute respiratory tract infection prescriptions, but there's more work to do. Implementation of a urine study order set with reflex urine cultures led to decreases in cultures and antibiotic use. Expansion of antibiotic stewardship activities to review discharge prescriptions increased appropriateness and decreased durations. Post-prescription review and feedback recommendations to decrease antibiotic exposure had lower acceptance than those increasing exposure. Verbal recommendation improved acceptance. Broad-spectrum antibiotic use increased in response to CMS sepsis bundle implementation. And last, MRSA NARS swabs have excellent negative predictive value for most MRSA syndromes. Thanks very much for your attention. Take care.